also quite new. That is a double feature, so I would like to invite Lucilla Poston and Carmel McNeary to give their talks. So Lucilla, as you all know, is professor and head of division in the King's College of London, and she is certainly one of the most outstanding pre-eclampsia experts in the UK and worldwide. And Carmel is certainly not far behind that, and she will give a talk after that. So I leave it to the two who have organized the double feature. Lucilla will start, and then Carmel will take over. Thank you very much.
Thank you very much, Christian. Thank you very much for the invitation. It's always very nice to come to the BHS. I used to come regularly every year, but unfortunately, if you're in obstetrics, there tend to be so many obstetrics meetings as well. But it's great to see so many old friends, and I'm looking forward to showing you a few of the highlights that are happening in pre-eclampsia. It's actually in a very exciting period of transition at the moment, and it's a fantastically interesting syndrome, we like to call it, not a disease anymore, to be investigating. And I have picked out, we have very little time, so before Carmel talks, I've picked out just one or two of the hot topics at the moment which I'd like to present to you, some work which we've been doing and ending up with a trial which we're doing in our unit at King's. So, talking about management very briefly, what NICE recommends at the moment is described in this rather complicated table. I don't want you to go through the whole thing, but essentially it's an integrated care package for women with pre-eclampsia, and it's a little bit simplistic in its approach. It's basically based on the level of hypertension in the individual, going from mild to severe hypertension. Doesn't take an account of the gestation of onset to pre-eclampsia, which is very important. And it recommends primary oral albuterol as first-line management, and then basically how many times you measure the blood pressure every day or week, depending on the severity of the hypertension, and monitoring with the traditional blood markers of renal function and coagulation and liver function. So we're all pretty familiar with that. But actually, if you speak to the clinicians, and I'm a scientist in the field, but I work with obstetricians all, and there are a lot of problems with the management of pre-eclampsia, and it's the source of a lot of trials at the moment, and indeed a lot of controversy and discussion. As I mentioned, one of the issues about the NICE guideline management is they don't actually take into recognition the fact that if pre-eclampsia occurs early in gestation, before about 34, 35 weeks, it tends to be far more severe in terms of its progression to maternal mortality, morbidity, and neonatal problems. So what do we do about that? The current diagnosis, which has been around for over 100 years, which is based on the measurement of blood pressure and proteinuria, is really out the arc. I mean, if you think about it, it's an end product of the disease when the kidneys become involved. They don't necessarily become involved in pre-eclampsia either. The definition of the American College of Obstetricians and Gynecology doesn't actually include proteinuria in the definition, but we still do. And it doesn't predict adverse outcomes. I mean, it's essentially being an endpoint of the disease. It's not very good at prediction of whether mother or baby is going to do well and need delivery, which is this, for clinicians, is really what we're talking about at the moment. We're just about to start a study of expectant management of late onset pre-eclampsia, whether to deliver or not, because there's a situation of equipoise and need for information there. So what we've all been saying in the field for over the last 5 years or so is that there's a need for sort of a new diagnostic test, and because what we've all been looking at is biomarkers, maybe that should be a new biomarker to diagnose the disease. But wouldn't it be good if that biomarker also could predict the severity of the disease, because that's what the clinicians need to know to inform management. So just to remind you what the current theory about pre-eclampsia is, on the left-hand side of this diagram, we have the normal situation where this is the mother, the decidua, the invading trophoblasts, which from the placenta, the epithelial cells in the placenta, and as they invade the spiral artery of the mother, they remodel the spiral artery, and it becomes more like a vein and a very low resistance to flow, and that leads to good blood flow to the placenta, to the fetus from the mother. But in pre-eclampsia, and also actually in fetal growth restriction to a degree, the invasion of the trophoblast into the decidua is imperfect. The tortuous spiral arteries don't get remodeled. You maintain a high resistance flow, low blood flow to the placenta, poor fetal growth. And the consequences in terms of the mother are this placental dysfunction. This is what's called the two-stage hypothesis of pre-eclampsia, leads to all sorts of nasties getting out in the maternal circulation. And if the mother, and we know quite a lot about them now, and if the mother is susceptible to, particularly if she has underlying renal disease or hypertension or obesity, or diabetes, she is more likely to succumb to the influence of those factors which tend to attack the endothelium and lead to coagulation, and these lead to the maternal complications. So there's a fetal disease and there's a maternal disease in preeclampsia, and that's the current theory. So what we've all been working on in preeclampsia for about the last 4 years is placental growth factor, which several of you will know is actually involved in cardiovascular disease as a risk marker. In preeclampsia, it's all a little bit different. PLGF is produced by the placenta, by the trophoblast, in huge amounts. It's bound in the maternal circulation to soluble FLT, and it's an angiogenic factor. So the idea is that there's an imbalance between soluble FLT and PLGF, in that the amount of free PLGF goes down. The placenta grows inadequately because there's lack of an angiogenic factor, and it leads to all sorts of problems. So if you look at the profile in preeclampsia, which has been shown probably in hundreds of papers now, but Levine from Boston was the first to show this. It's very different. And early in pregnancy, and I don't have time today to go into the prediction very much of preeclampsia, but there's a huge amount of interest in using it as a predictive marker in combination with other biomarkers. What I'm talking about today is actually its use in diagnosis. And the reason is that those women who get preeclampsia have very low levels at the time of disease of PLGF, and it's much lower in those who have early onset preeclampsia. So obviously those of us who have been concerned about having a good diagnostic marker which is going to tell you about the early onset and the severity of disease, this looked like a really good candidate. So the whole of the preeclampsia world is doing this at the moment. Wherever you are, everybody's interested in PLGF as a potential diagnostic biomarker for preeclampsia. And basically, I think I would suggest in 5 years' time we're going to see blood pressure and proteinuria, at least proteinuria, maybe not blood pressure, being sidelined a bit. There are different ways of measuring it, and the study that we've done at St Thomas's used the ALEA platform. We've worked very closely with the manufacturers of this test, which is incredibly sensitive. It's a bedside test. You take blood, you spin it. At the moment, you have to use plasma rather than whole blood, but they're developing a whole blood test. You put the blood into this little cartridge on the left-hand side. It's capillary action. It goes up. Then Bob's your uncle. You put it into the machine, and then 15 minutes later, you get a result. It's one of the 3 or 4 that are on the market at the moment, but it's being widely marketed now. So the study that we did, and there are 3 or 4 of these which have been done across the world, and some are still ongoing, is that in women who we think may have preeclampsia, any of the signs and symptoms with raised blood pressure or proteinuria, but not with diagnosed preeclampsia, you come to the day assessment units, is the measurement of PLGF at less than 35 weeks, and I'll tell you why we use that, gestation. Does it predict preeclampsia as measured conventionally, but preeclampsia which is likely to lead to early onset delivery through complications. So it's quite a complicated hypothesis, but actually every element of that has been well worked out. Why 14 days after the test? That's because obstetricians tend to see women every 2 weeks, so it'd be nice to know before the next visit whether this woman is at high risk. 35 weeks of gestation, because early onset preeclampsia is particularly important. We focused on that. This study actually also included measurement later on in pregnancy, but I don't have time to show you all the results. And this paper is in press in circulation, so you'll be able to see the results for yourselves quite soon. It was called the Pelican study, done in 7 UK sites and 1 in Ireland. Those women who suspected preeclampsia at less than 35 weeks, 267. To cut a very long story short, this test has extremely high sensitivity for preeclampsia as measured conventionally, and the diagnosis being carried out by a panel of judges in this study, and less good specificity. But the really good element about this test is it has a very high negative predictive value, and obviously we'd like the specificity to be higher, but the sensitivity is extremely good at picking up nearly everybody who develop preeclampsia requiring delivery through severity. And that's just one way of mapping it out using an area under the curve. So those women who have very low preeclampsia, the red line, very low PLGF, the red line, and they have obviously a very high area under the curve, ROC curve. Those women who have lower, slightly higher, the low group, lesser of an area under the curve in terms of delivery, and these are the normals. So it gives you a really good estimate of women who require delivery within 2 weeks. There are lots of different ways of skinning this cat. Many people have done this study in a slightly different way. There's a paper which looked at PLGF over soluble FLIT as the marker. But every single publication on this is now pointing to PLGF being a sensitive diagnostic marker for preeclampsia and specific, but also picking up women who have severe preeclampsia, which is what the clinicians need. And if you look at it, how it compares with other more conventional tests at the moment, so the area under the curve here for all those other things which are measured, systolic, diastolic blood pressure, urate, ALT, they don't do nearly so well as PLGF, and indeed if you add them all together and put them with PLGF, it doesn't make any difference to the PLGF curve, so PLGF is as good. Here are the combination of them all on their own. So this study has created a bit of a stir, as have all the others from the United States and so on, and we are all getting quite excited at the possibility of using low PLGF. Probably with, I'll go on to show you some more work now which has been done from Vancouver, which has also developed an algorithm for estimation of severity of disease. But this test is undoubtedly not going to go away, and it will be used either alone or in combination with the other biomarkers of adverse outcome. So this is the study. The other study I just wanted to point out to you, which is also discussed very widely in preeclampsia circles. I'm involved at the moment in an application to the Gates Foundation to do a study in Brazil on prediction and management of preeclampsia. And indeed, the part of the management is based on what we call this full peers test. So this was done by Peter van Dadelston and was published in the Lancet in 2011. And essentially, it's an algorithm which puts together a number of, this is women with established preeclampsia, a number of factors, and they chose many different ones to look at, but these in red are the ones which came out as being predictive of adverse outcome within 48 hours. And you'll be interesting to see that systolic blood pressure is not one of them there. Be a brave man who didn't measure blood pressure, I think. But lower gestational age, as I mentioned, is very predictive of adverse outcome. And then chest pain, higher creatinine, high ASTs, lower platelets, and usually and unexpectedly the oxygen saturation by pulse oximetry. So you put all those into an algorithm, very well described in the paper, and it gives a ROC curve of 0.88 for adverse outcomes within 48 hours. Now, for the obstetrician, that's a useful test because the mother is going to have to be delivered, and if the mother is in early gestation, she's going to need to be given steroids, and it would be a very good indication for giving steroids to the woman who's deemed to be at particularly adverse risk within 48 hours. So to rattle on now, a lot of the work that I've been doing is on prediction of preeclampsia, but I don't really have time to talk to you about it today. But just to, at the moment, all we have in terms of prediction of preeclampsia, which is recommended by NICE, is by clinical and obstetric history. So that's previous preeclampsia, gestational diabetes, renal disease, chronic hypertension, and obesity. And if a woman has more than one of those, then it's recommended she goes on to low-dose aspirin early in pregnancy. But one of the problems about using clinical history is, for previous pregnancies, is that the largest group of women who develop preeclampsia actually have never been pregnant before, so that has produced a real problem because we don't have any tests for them. And also, there's likely to be a different test or algorithm for prediction required for different risk groups, and this has really been something which has muddied the field. I don't really want to go into it now, but healthy nullips, for example, seem to have a very different risk profile in terms of biomarkers than higher risk women. So what the whole field is moving towards is a screening test which combine biomarkers and clinical risk factors to predict preeclampsia. There's a huge literature on it out there now, but nothing yet has been deemed to be good enough for NICE. I've been involved in a study, an international cohort study called SCOPE, which is screening clinical endpoints for preeclampsia. This is a study designed to assess risk in nulliparous women. The whole study actually has been 5,500 women. This first paper was produced on the clinical risk factors in the BMJ in 2011, and we've just completely finished the study now. We've been measuring hundreds of biomarkers, and those papers will be coming out in the next 6 months. But this first tranche looked at the first cohort of women from Australasia, which were from Adelaide and Auckland, and described risk factors associated with the later development of preeclampsia as measured at 15 to 16 weeks of gestation. Some of them are pretty obvious, having a slightly higher blood pressure, but also some interesting ones, including, for example, a family history of coronary heart disease. And a family history of cardiovascular disease has come out loud and clear in this study and the subsequent study of 5,500 women. And interestingly, as has been shown before, a decrease in the woman's own birth weight. So some developmental programming perhaps going on there. And another is vaginal bleeding and repetitive vaginal bleeding, less than 5 days and beyond, and other new studies have been showing that too. So some classical risk factors we know about, but some which we're a little bit surprising. These have been put into an algorithm. We're now refining the algorithm with a complete cohort, with the Northern Hemisphere, comparing Northern and South. So, as I mentioned at the moment, prediction and prevention of preeclampsia, what do we do if we know somebody's at risk? Well, actually, we can't do an awful lot. So what is recommended that those women deemed to be at risk are given low-dose aspirin. The relative risk reduction is in all the meta-analyses suggest about 17%. In the recent analysis, more recent analysis of individual patient data, a 13% reduction. And there are some studies at the bottom here which suggest that if you start aspirin treatment early, less than 16 weeks, you're likely to get a 50% reduction, but actually they're very small number of patients in those studies. The other more controversial area in terms of prediction and prevention is when a woman is deemed to be at high risk, you give her calcium supplementation. Huge controversy about that. If you look at the Cochrane review, it would suggest that everybody should be given calcium supplementation. The problem about it is actually that if you look at the neonatal outcomes, they're not improved by calcium supplementation. Essentially what you're doing is reducing the blood pressure and not improving the pregnancy outcome. So the world is divided as to whether one should give calcium. Again, the study that we're planning in Brazil, we will include, as according to the WHO are now recommending calcium supplementation for women who have calcium deficiency in their diets. But in terms of actual neonatal outcomes, I have my doubts as to whether it's really worthwhile. So just to finish up, I'm at the moment doing a big study on obesity in pregnancy, which isn't notably directed towards preeclampsia, but of course it is very relevant. This is from data from the SCOPE cohort, which was published last year, looking, as we all know, nothing new about this, that as the woman becomes heavier and her BMI increases, her risk of preeclampsia goes up quite dramatically. Nothing new about that. What was interesting about this study was that everybody had considered that obesity-associated preeclampsia tend to be late-onset preeclampsia, maybe less severe, and in fact this study shows that early-onset preeclampsia goes up in proportion to the number of women who have preeclampsia, so that theory has gone out the window a bit. They have as much preterm preeclampsia as other groups. So just to finish off, I'd like to tell you a little bit about this trial, which is known as the Upbeat study, which has been we've been working on it now for 3 years, and it's a complex intervention study, something new for me. I'd never done anything on lifestyle intervention. 1,546 obese women, it's BMI over 30. And we have looked at, we've done a pilot study, which we've just published. And in that pilot study, we wanted to show that the intervention actually changed women's behaviour. So that the intervention is dietary advice, which includes a low glycemic index diet, because the primary outcome of this study is actually prevention of gestational diabetes. But also we recommend increased physical activity. And this is quite a severe intervention given over 8 sessions with a health trainer. And we did show in the pilot study of 183 women that we very significantly changed the dietary habits of these women, which I was very pleased to see, because it wouldn't be much point in proceeding with the study. But we weren't able to change their physical activity as measured objectively with using an accelerometer. But we're continuing on now. We've now recruited 1,153 women, I think, yesterday. So we're heading towards the end of this study. But of course, one of the secondary outcomes that we're going to be looking very carefully at is preeclampsia. and to see whether these interventions might improve pre-eclampsia because of its association with glucose intolerance. But also, we've been funded now by the MRC to look at novel biomarkers for prediction of GDM and pre-eclampsia in the early pregnancy samples from these women, using metabolomics as well as a more conventional approach. So hopefully we may come up with a few interesting and new biomarkers. So this is just the protocol for the study. Women are randomized at 15 to 17 weeks of gestation to either, on the left-hand side, normal antenatal care, because they all have BMI of over 30. They're all having an OGTT, which is according to NICE guidelines. Now, not all women, as we know in clinical practice, who have BMI over 30 do get an OGTT, so there's going to be an influence of this on the trial outcome. There's nothing we could do about it because we're adhering to guidelines. And then the intervention arm, 8 sessions with a health trainer. And we're measuring a huge number of variables, clinical and biochemical. And then we are funded also by the European Union to look at the children as they're growing up to 3 years at the moment, with the idea that in utero exposure to obesity can lead to potentially an increased risk of obesity and cardiovascular disease in the children, and we have a BHF grant to look at cardiovascular function. So I'm going to leave it there. I haven't done any of the work on the ground myself, but a huge number of people have been involved with the Pelican study, also the Upbeat study with a team of about 30 people around the UK. So there we go. I hope that gives you a sort of snapshot of what's happening in pre-eclampsia at the moment. Very fast, but I'll be very happy to talk to any of you later at coffee to give a few more details. Thank you very much.
Lucilla, thank you very much. I think because of the special format of this first talk, I think we just carry on with Carmel and then you may take some questions.